called?
Is it called?
Yeah, you guys need to document it.
Okay. This video.
I've had one before. I had a stomach ulcer when I was little.
Can you answer questions while you're doing it, or do you have to concentrate? Okay.
Like an introduction.
So,
do an introduction to it.
hello guys. This is our group, and as you can see, we are learning ultrasound today. So while she's doing this, we're gonna ask questions, and she's also gonna explain to us what she sees.
So I'm going to just simulate that I'm doing a right upper quadrant.
Okay.
And we kind of have a protocol that we follow. So our first organ that we usually look at is the pancreas, which is this kind of bright structure, what we would call a hyperechoic, a bright structure. And we use a lot of vascular landmarks to be able to identify the different organs within the body that we need to see. So there's her pancreas. This kind of looks like a little tadpole there. And then my next structure that I usually look at is the liver, which is the second largest organ in the body. Anybody know what the largest organ is?
I'm supposed to answer this. The brain.
I'm just kidding. That's a big one too.
Okay, well, this
Say it. You almost said
stomach.
it. Ah,
Spleen.
The spleen.
No, it starts with an S though. Still.
We should know
I'm
this.
touching it right now on the outside of you. The skin. The skin.
Duh.
The spleen's not very big.
We're gonna cut that.
Just kidding.
Cool.
So here is her liver. Liver's a very vascular structure. So in addition to taking what we call grayscale images, we also use a lot of color Doppler.
So what do the colors mean?
So red, okay, so Doppler first of all indicates blood flow. It indicates that something is moving. In this case, red means that it's moving towards the transducer. I use my little color scale here. And blue means that something is moving away from the transducer. So for instance, this is her main portal vein, and it's going towards my transducer. It's taking blood flow up into the liver, whereas this is the IVC, or the inferior vena cava, so it's taking blood flow away from my transducer.
That's cool.
Yeah, we have fun toys.
Okay, I'm gonna ask you a question.
Sure.
What is the hardest part of your day-to-day life working as a sonographer?
The hardest part of my day-to-day life, I would have to say the hardest part for me is trying to do more with less all the time. You know, the department that I work at, we're short-staffed, we're chronically short-staffed, as are a lot of imaging departments, and I hate to make people wait, and I hate to rush through my exams that I do. So yeah, it just makes it hard. It's hard on your body, it's hard psychologically. I think it can lead to some unsafe situations sometimes, especially when you're trying to do invasive procedures with only one sonographer and one radiologist. I don't think that's a safe type of situation. So yeah, I would say that's probably what I consider the hardest part of my job.
Why do you think, why is sonography so limited in the amount of people that are in the field?
I think it's just like every other healthcare modality right now. I think a lot of people left during COVID. I think that, they're exploring other career options. A lot of people like to, work at home or work remotely now. I think people are still afraid of COVID and the long-term ramifications of that. And I just don't think that we've recovered from that fully. And I think it's gonna take a while until we do. So, yeah, it's a tough situation right now.
Okay, can you give us a rundown of your daily exams in sonography and what you might see most of?
There's her kidney. Here, I'll label that too. All right, so my practice, currently I work in a general department, in a radiology department. So I do a lot of abdominal work, so livers, kidneys, gallbladders, spleen, pancreas, bile ducts, things of that nature. We also do a lot of GYN type of work, so female pelvic ultrasounds, pelvis or uterus, ovaries, early pregnancy. I do a little bit of OB work, usually more on an emergent basis, because most doctors have equipment in their own offices where they refer their own patients to do their OB work. So most of what I do is more emergent. So like maybe the patient hasn't felt the baby move, maybe she's having some bleeding, maybe she goes into preterm labor or something like that. Or in early OB, worrying about ectopic pregnancy. Is the pregnancy in the uterus, or is it somewhere that it's not supposed to be, which could be a potentially life-threatening type of situation. In the general sonography department where I work at, we do a lot of vascular work too. So a lot of blood vessels, carotid arteries that take blood flow up to the brain. Lots and lots and lots of lower extremity venous exams to make sure a patient doesn't have deep vein thrombosis, which is blood clots in the lower extremities, which again can be a potentially life-threatening type of situation if they break off and cause a pulmonary embolism, obstructing the blood flow or the vasculature to the lungs. I do some work in the NICU. I look at little baby brains because in the first few days of life, it's not unusual for those premature babies to develop bleeds in their brains. So we do quite a bit of that. Where I work at, we also have a pediatric ER as well. So looking for appendicitis in folks. So I guess that's one of the things that I kind of like about working in a general department is there's a wide variety of things we do. We do a lot of invasive procedures too, so thoracenteses to drain fluid off the lungs, pleural effusions, paracenteses to drain ascites, liver biopsies, thyroid biopsies. You know, no 2 days are ever the same. Big variety of the kind of things we do, so it never gets boring. There's their gallbladder. Big black hole, which is normal.
Do you have one piece of advice you would share with someone that's interested in sonography, or what you might tell them to get into the field?
To get into the field of sonography, you know, a lot of science, you know, heavy on the science classes. You know, make sure that you keep your grades up. It's not the only thing that we look at, but that is important. Sonography is a very operator dependent type of modality, you know, so if I don't see it, the doctor doesn't see it. So I think taking your time is important, not rushing through things, doing your due diligence for all of your patients, staying on top of continuing education, you know, because just like any other kind of imaging modality, sonography is always changing. So, you know, knowing what the latest protocols are, what we need to be looking for, being familiar with different types of pathology and disease processes, and, you know, just being confident, doing the best you can for every patient. And if you have questions or you need help, don't be afraid to ask questions. I mean, I've been doing this for a long time, but even when I worked in the vascular lab, I would still go get one of my partners and say, hey, I need another pair of eyes. Come look at this with me. And that's okay. There's no shame in that. So, yeah.
So, like, looking at this, it seems like really hard. Like, I have no idea, obviously. How long did it take you to actually, like, kind of
Get the
get
hang of it.
used to it? And, like,
So it's funny that
know
you
what
say
you're
that,
seeing.
because when I was in x-ray school, like you guys are, we did a 2-week rotation through ultrasound when we were seniors, and I was like, I don't see anything on that screen, and I'm never gonna do this, so I'm not even gonna pay attention to this, la 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 la, you know. Well, my motto is always never say never, because you never know where you're gonna end up. And I was offered a job to cross-train in ultrasound years ago, which at the time there weren't a lot of ultrasound schools, so that was really kind of the only way to go, was they cross-trained a lot of radiographers. And I wasn't going to do it. I was kind of scared of that. I was like, I don't know if I can do that, because I don't see anything on that screen. And a very good friend of mine explained it to me that once you look at enough things that are normal, when something is abnormal, it stands out to you. And I think the same holds true for radiography as well. And that kind of made sense to me. I was like, okay, all right, maybe I can do this then. So, we really hit the normal anatomy, lots of repetitions, just like you guys, we do thousands of hours of clinical education so that you can get a feel for what something should look like, and then when it's not normal, it's going to stand out to you. So that's kind of how I got into radiography. I kind of went on the accelerated plan. They taught me very quickly, much quicker than they probably should have. I made some mistakes early on. Yeah, we all make mistakes, nobody's perfect. But our students do about 2.5 years in the program, but they're also learning 3 different modalities: abdomen, OBGYN, and then either echocardiography or vascular ultrasound. So in order to get a good feel for 2 of those modalities, abdomen, OBGYN, I would say about 1.5 years. And then another year of clinical education for the specialty areas, echo or vascular sonography is a good time frame.
So since you do know both x-ray and sonography, what would you say was the most difficult or hardest part in transitioning from x-ray to sonography?
Well, I would like to say, first of all, that I'm very grateful for my radiography background, because I think it gave me a good understanding of a lot of different modalities, cross-sectional imaging, but most importantly, my patient care skills. Okay, my patient care skills are top-notch as a radiographer, I felt like. I think that's kind of a weakness of our sonography program. I'd like to see my students have more patient care experiences like you guys have. Probably one of the hardest things is that radiation physics and acoustic physics are just the opposite of one another. You increase the kV, you increase the penetration power of your x-rays. You increase the frequency of a transducer, you decrease the penetration power of your transducer. So it was kind of like, how do I wrap my head around this, to make sure I understand 2 different sets of physics, and how sound waves versus x-rays interact with the human body.
Can you explain to me the different types of transducers and the sizing?
Yeah, absolutely. So we have a wide variety of transducers. Some places that you go have a whole buffet of transducers, I like to say. But this one here, this is what's called a curved transducer, and you can probably kind of guess why, because it has a curved footprint on it. This is what we call a 5 megahertz transducer, so it's got a 5 on the outside there, and that's just the frequency at which it operates. And this is kind of our workhorse. We use this for a lot. We use it for almost all of our abdominal work, our pelvic work, our OBGYN type of exams. It gets used quite a bit. This is what we call a linear transducer, and again, you can probably guess why, because it's straight on top or it's flat on top, and it's this particular one is a 12 megahertz transducer, so a lot higher frequency. That means it's not going to be able to penetrate as deep in the body, so it's for more superficial structures in the body. We use this a lot for carotid arteries and veins that are close to the skin surface. Thyroid ultrasounds that are close to the skin surface too. So we use this one quite a bit as well. And then this one here is what we call a phased transducer, and it has to do with how the machine electronically steers the beam, which is kind of a physics concept, kind of beyond my understanding too. But as you can see, it has a really, really small footprint. Okay, so this is what they use for echocardiography, because you're working around ribs, you're working around the sternum. You need to be able to get into those really small spaces to be able to image the heart, and this is the ideal type of transducer for that. And you know, that's just 3 different transducers that we have. They come in all shapes, all sizes, different frequencies depending on whether you need penetration or if you're imaging superficial structures. And that's not even getting into the 3D probes too, which can take those 3D and 4D images, which normally you think of the cute little baby faces, but and that's one of the uses that we have for those, but there's other uses for that as well too. So there's a lot out there, and you know, we're lucky enough to have what we have, but brand new, you know, each one of these is about $10,000 to $20,000. So yeah, and they're delicate, you know, so we don't want to like bounce them off the floor or anything like that too, because they can break pretty easily. That's a good question.
Can you show us like just some basic things on that ultrasound machine and what you use most of?
Okay, so obviously the display screen, so you know that's where we're going to be viewing our images at. Up here where it says patient, that's where I can put in all of my patient information, as much or as little as your institution wants. In most hospitals then, this is going to be hooked up to the RIS and to the DICOM, so it will automatically populate with my patient list, so I just have to select that off of the screen that way. Once I have my patient, I can select which type of transducer I want to use. So depending on what transducers I have hooked up to the machine, I can tell them which one I want to use. So you can see the shape on the screen just changed there. So this is that little phase transducer I was showing you guys. And it is set up. I have other presets on the screen that I can use. This one happens to be set up for adult echocardiography, so I'm going to be using that for the heart. If I put measurements or if I want to type information into the machine after I do an exam, I can hit this report screen, and then I can edit the report, and I can type anything that I want to into that box. That's what's called a sonographer's technical impression. It's not a diagnosis, because we're not doctors, we don't diagnose, but we can convey important points of our exam that we want to draw to the interpreting physician's attention so that they can pay particular attention to that then. What else do we have? I have lots, it looks like there's a lot on here, and you know, we just kind of learn one thing at a time. What does this button do so that it doesn't get too overwhelming? But I have buttons that change the depth of how deep I can penetrate into the body. I have a focus button that kind of shifts where my focus is on the screen. I can zoom in on things if I want to. Okay. I have acquire buttons that let me save different images. I have a freeze button that lets me stop my image and take my pictures and then unfreeze to begin my exam over again. I have a labeling button where I can label whatever I want to on the image so that the interpreting physician knows what structure I'm looking at. If I don't like what's on there, I can pull up a keyboard and I can type any of my own stuff too, which is kind of nice. I have measurement keys where I can measure the size, the shape of different structures as well. And then I mentioned color Doppler earlier. So color Doppler tracks movement, just like Doppler radar. You know, Doppler radar today is tracking storms. My Doppler is tracking blood flow. It's tracking movement of red blood cells within the body. I can also have a setting called pulsed wave sonography, and that's the one that allows me to get an audible signal of the movement of that blood flow. So, you know, you hear on TV shows all the time the whoosh, whoosh, whoosh of the baby's heart rate, and it's not just baby heart rates, it's any kind of blood flow or movement through the movement of blood through the cardiovascular system. I have what's called a gain setting where I can turn up the sound power so I can image structures better, or I can turn it down if I want to make my images a little bit darker. So it looks kind of overwhelming, but there's certain buttons that we use a lot, and then there's certain buttons that we use just to kind of fine tune our images, but they're not used as frequently as some of the other settings on the machine.
Well, thank you for explaining that.
Yeah.
You are sure welcome.
Doing an exam on our friend here.
Yeah. Thank you for being my guinea pig here. Your liver looks lovely.
Thanks.
Gallbladder looks lovely.